Good morning. Well, first of all, I would like to thank all the organizers. They were excellent when it came to organizing this meeting, and on a very timely basis, in a very timely manner, and the venue is also stunning. Well, I am also surprised because, well, we are talking about a rare disease, but we tried to pool our strength and our interest. There are some reasons for that. First of all, this protein is crucial from a functional point of view, and then we also have all the clinical characteristics and features of the patients suffering from this disease. Well, I will try to set out and outline my task in my presentation. We'll talk about children suffering from this disease. It is very difficult to talk about studies and movements without showing videos, but I decided not to show any videos from my patients because well, this is something confidential. Maybe you wouldn't have liked it. Well, I will be a little bit boring for all of you because sometimes it is more useful to look at what is being described with words. This slide is just a presentation slide about this disease. Well, this disease has shown over years, over a few years, a very broad spectrum of phenotypes. Well, at the beginning it was like a disease that came up as an alteration of genes, and then, well, epileptic encephalopathy and encephalopathy, and then, well, a very broad spectrum concerning all different manifestations like studies of movements, etc. And the third characteristic, which is very important also, is the intellectual disability and impairment and the delay in all these children. This is just a slide to share with you how complex and complicated this is. So we have epilepsy, we also have movement disorders, and the third symptom, I won't go through, is this delay, which is a constant symptom in this condition. Well, this review shows in a very schematic way the movement disorders that we can see in patients suffering from GNAO1. Well, we have chorea, we have dystonia, we have dyskinesia, for example, movement disorders, and the literature also shows these symptoms not always in the same way, so not always the same words I use. Sometimes we talk about dyskinesia, for example, to mean a movement locomotor disorder that we cannot characterize, and sometimes the children can also have chorea, very, very fast movements in a specific age group, and then also show other types of symptoms. This is something that is not always taken into account in literature, and this is also one of our tasks. So we should also try to better focus on this clinical condition and all the symptoms that can come from this disease. Well, another interesting figure is not just the average age, but the range we have, because movement disorders can come up from 3 months to 8 years, so a very broad range and a broad range of time. And then we also have other studies in literature, for example, stereotypes, for example, behaviors, self-injuring behaviors, they bite their own lips, and this is something that can be also temporary for some of the children. And in some cases we also have pyramidal signs, and in some cases we also have other cervical disorders like dysphagia or dysarthria, etc. And all these characteristics are not relevant in terms of quantity. They cannot be measured because they can be collected when we read scientific articles. What are the key points for all of us, the ones on which we try to focus? We do have some specific characteristics for this movement compared to other diseases, and this is a key, a crucial issue also in terms of early diagnosis. We realized over time that the ability to detect this disease has improved a lot. So the first diagnoses were carried out when the child was like 5, 6 years old. Now we can detect it in children that are like 7, 6, 7, 8 months old. So we are more sensitive towards the characteristics of this disease. So we do have some peculiar semiological characteristics thanks to which we can detect this disease and distinguish it also from other diseases. And then we also have other characteristics in terms of onset of the disease and also external triggering factors. And if the genotype, for example, was reported or not. And this is important to predict also movement disorders that will come up in the child. And this is one of the most important ones. So the natural history of the movement disorder of the disease. What is the course, the progression of the disease in children? So if we can learn something also from preclinical models, trials, mice that were modified, etc., and a broader, a more general problem that came up at the end of the previous century when this concept was also defined, neurodevelopmental disorders. And here we also have another problem. So we have this kind of disease that was described by Zogby for one of the diseases that had the same characteristics, the Rett syndrome at that time. Well, I cannot go into details about all these topics, but I want to focus on two important, two crucial cases that might turn out to be very useful. And in the video had shown all these aspects, but in any case, I will describe them without showing them with the video. These are not isolated cases, but we have different kind of onsets here. This is a child. He is 5 years old now, and he had at birth some breastfeeding difficulties, temporary difficulties. In the first month he had a delay that became more and more evident over time. Then we have also some maturity problems and startle reflexes, low threshold reflexes, hypotonia, which is quite a weird symptom, above all because it is not always identified as such. Sometimes we talk about hypotonia, but it's not exactly hypotonia. But over time, as month went on, this child got better. So the control of the head control, he can grasp an object, for example. So some reactions that are also foreseen for his age that were achieved, even if a little bit delayed. And he is a child who is interested in the environment. He was able to interact, to follow people. At 18 months, he had a development that was comparable to the development of a 10-month-old child. And then at 24 months, there was kind of stop in the development. The hypotonia goes up and develops. Then he doesn't move a lot. So we start talking about hypokinesia, so hypokinetic children. And then we also have apostural status and action-induced choreic and balic movements of the trunk and limbs. So choreic movements that are more and more frequent. Well, at 36 months, we also have some disabilities and impairments. For example, he bites his teeth and he moves his teeth in a his lips, and moves his teeth in a very peculiar way. Then we also have some focal epileptic seizure. It is very difficult to stop all these movements, and for for hours or for some time, for days, for example, like high temperature, fever, emotional reactions of any kind, and then he starts having epileptic manifestations and symptoms. So this is just a movement disorder. This is one of the patterns for the onset of this clinical condition. Then we also have another case, case 2, as you can see here. Well, we try to focus on this specific aspect. Here we have a specific recurrence, so feeding difficulties, temporary difficulties during the first weeks of life that can be solved later on. This is a girl, well, with a delay in development, but she gets better over time. She improves. She can speak at the age of 18 months. She can also utter the first words. So we do have a delay in development. At 24 month, we have a spasticity in this case and a specific kind of palsy, cerebral palsy. But at the age of 4, she can walk, for example, 4 years and a half, and at the age of 7, she can also be included in quite a standard school. At the age of 8 years, she has normal dyskinesia. In this case, she was unable to walk. She is very, very slow in terms of movements, something that cannot be stopped in this case. And in spite of the pharmacological and drug treatment for 1 month, then a new therapy is administered, and in this case we were able to stop these symptoms. For the first 2 years, she is quite good. Then she has sometimes fever, high temperature. She has a relapse, for example, during these involuntary movements. But all in all, she goes on, and at 10 months, she has a new fever, high temperature once again, and dyskinesia once again that goes on for a very long time, and she can't control this condition, and she also has muscle disorders and kidney failure. And she spends 6 months in the intensive care unit, and then we have a new treatment, a pallidotomy in this case, because we cannot stop the symptoms. So these are two extreme situations, and not all children are part of the first group or the second group, but this is the focus here are movement disorders. What can we think about the future also? And what can we also predict on children? Well, all these symptoms start up at an early stage, and the outcome is very different. In some patients, these symptoms can be stopped. In other cases, we have very severe complications. So we do have some factors that can trigger the movement disorder, like fever, excitement, stress, pain, or position change, posture change. We do not have any markers that make us understand when movement disorder starts. So if the dyskinesia is short-lasting, long-lasting, we do not have any biomarkers that can be useful and that can help us in this very crucial task. So a couple of remarks I would like to share with you on the movement disorders. So first of all, this is something that is always present in these children. Sometimes we have an early onset of the GNAO1, and movement disorders are also characterized by disorder in terms of postural control. So they cannot control their posture, for example, gravitational control. They are hypotonic but also hypokinetic, so they cannot move very well. So the spontaneous movements are are reduced in those children, in these children, then we also have the recurrence of choreic movements that brings about some movement disorders, further movement disorders. Every relapse tends to impoverish the children in this case, and the time he needs to retrieve, to recover from one crisis to the other one. As far as the late onset patterns are concerned, here we have a very free period, let's say, that might also be very long, and there is a delay here in the acquisitions also. This is quite important. And if the onset is late onset, the prognosis is not necessarily better than in children that have an early onset GNAO1 defect. The genotype can also affect the prognosis. We don't know yet. Patients are we do have very few patients. There are some genotypes that are associated with movement disorders, as in this case here, so some genetic mutations, and Mrs. Valenti will focus on that. And we also have other symptoms that are associated with epilepsy, and sometimes we have movement disorders and epilepsy, both of them, so also this mutation of the phenotype, which is not still satisfactory, actually. Well, what about the natural history of these MD and the GNAO1 patients? Because when it comes to a new disease, we have to understand what kind of developments that the disease has, because otherwise we cannot plan any treatment or therapy if we don't know the natural history of the disease. We don't know it, we just have anecdotes, and some of them will be shared with you. Mrs. Carecchio will talk about that for adults, for children, for example. There are no systemic data about the outcome of patients, and but we can also take advantage of genetics and what is offered by genetics. Here we have a chart in which we have children with the same mutations, so movement disorders. We also have these characteristics, so the early onset of the disease. And what you can see here, if we select the patients, so the older patients, like 14, 15-year-old patients, even if the genotype is the same here, we have some very different patients. In some cases it is better, in some other cases it is worse, but the same applies to this mutation. Here we have very few patients with an age that is quite advanced, let's say, so they are quite old, so to say. And in this case, we can also say something about the natural history of the disease. Animal models can be very helpful. I identify 4 of them. 2 of them are lockout, so the situation in which there is no gene, so lockout. And in these animals, the survival is very limited, let's say. So they have very short, very low possibilities to survive, and up to 50 days in some cases. And another interesting element that we identified in these models is hyperalgesia. We will talk about that also later on in the afternoon when it comes to rehab interventions. These can also trigger dyskinetic crises and seizures and fits. So this is something we have to take into account. It's very difficult to understand if a child is suffering from hyperalgesia. This is can be more easily identified in mice. And then this is a slide that was changed because I made my presentation on my MacBook, and this is another computer, so it is a little bit different. But anyway, even if there is a problem with coordination in mice, and even if we have an alteration, a change in terms of movements, well, he's not very good at moving. Well, he's very compulsive and impulsive, and this is an anti-clockwise movement, and these movements are behavioral movements, not just traditional or standard movement disorders as we mean them. And here we have another slide that was changed due to this passage from MacBook to this computer, but these models were also studied as single mutations that can be also found and detected in human beings. This one is not present in human beings, but what comes up is that when we change the mutation, then we can also make distinctions between female and male beings. So girls are affected by epilepsy and less by movement disorders, and the contrary applies, the opposite applies to men and boys, for example. But this is something we do not know much about. This is a theoretical problem that should be postponed. We will have a very nice presentation, a speech that will be delivered in the afternoon that will give us also an idea if this can be a kind of neurodevelopmental disease. And I would like to close my speech with one of the patients I got to know yesterday. I was authorized by him because it was a little bit different from other patients. He's 18 years old, and he also had an early motor delay, in this case 12-month sitting position, 9 months he started walking, and then there was a diagnosis of late development, and at the age of 7 years there was a focal diagnosis, so an oral and oculomotor dyspraxia. He has always been very slow. This is one of the distinguishing features of this boy. At the age of 9 years, there was a diagnosis of instability in terms of attentive resources, so attention deficit disorder, and methylphenidate was administered to him to stop these symptoms. At the age of 11 years, this therapy was stopped. He was able to write, but he had no verbal skills. At the age of 11, methylphenidate was stopped because it was not effective, and he developed a dystonia on the upper limbs, and now he has improved once again. Between 11 and 14 years, he developed a sort of axial hypotonia, hypo and bradykinesia, and a cranial dystonia, with the stagnation of improvements and learning abilities that were achieved up to that moment, and the dysphagia also, and difficulties when it came to swallowing. He was treated with several drugs also for Parkinson's disease, and also another important drug that is hexiphenidil, that is also used for Parkinson, and the combination of these two drugs, so trihexiphenidil and methylphenidate plus trihexiphenidil, this brought about an improvement of dystonia and oral dyspraxia. At the age of 18, we have hypokinesia, dystonic posture of trunk and limbs, spastic gait, severe cervical dystonia with dystonic dysarthria, a mild moderate intellectual disability, but the symptoms are slightly better than in other patients, and also there's never been a chorea, that is a constant symptom in GNAO1 deficit. Thank you very much.